if I need to be precise, let's be precise in everything. Let's use every monitor for every patient. But it's not that accurate. Let's think of this in a different way. Let's say that we have two categories of organs. We have the supporting organs, like lungs, kidney, muscle, and for this organ, I need to be on the right hemostasis and to keep them on the right hemostasis. But I also have the target organ. The target organs, that means that they are being altered by the anesthesia. And every time, I need to seek for the right measure of everything. So for the brain and for the cardiovascular system, we do have many, many monitors. But for the autonomic system, most of the time we are just waiting until we have hemodynamic reaction, respiratory reaction, or if my patient is moving, maybe it was good to give him fentanyl before. So the Medicine Society think and reach this monitor of NOL, and we can see quickly how it works. On your left, you have the noxious stimulation of the surgeon. On the middle, you have my sympathetic and parasympathetic balance, the vagal tonus. And according to this activation, we will get a sympathetic activation, and after we will get a hemodynamic respiratory of movement response. So the NOL monitor is just a monitor that, it's a clever monitor, that measures 4 parameters, temperature, conductance, movement, and photoplethysmography, in order to estimate this vagal tonus. And this is really important because this provides the opportunity to react before the sympathetic activation. And I'm just reaching for the right measure of anti-nociception. And of course, I'm reducing my side effect like we said. I just want to tell you that you need to learn this monitor because it's really a practical one. It's measuring the tonus, the vagal tonus, and that many other things can impact this monitor, but you have to learn how to use it. It's really simple because in the hand it's just giving us this index. We have to be above 10 and below 25. What does that mean? Above 25, that means that my patient is a sympathetic part. And for us, that means my surgeon is hurting my patient and I need to give him fentanyl or something else. But also, if I have a NOL monitor under 10, that means that my patient have more than necessary remifentanil or fentanyl or what you want. And you have to reduce the doses. It's really important because it's also a new thing to think like the right measure, not more, not less. So I have 2 questions in order to explain more on the NOL monitor. Very simple. Who, why? As for who, I need to use the NOL monitor. For the patient that I have a doubt on my target organ, if I have a patient, drug abuse or chronic pain under opioids, high level, is taking opioids every day, how do I know that I'm doing a good job? How do I know that I'm not giving more or less than necessary? Also, I have a patient with very high blood pressure. Okay, so during the surgery, I will get 170 systolic blood pressure, and I need to differentiate if it's because my nociception and my patient I need to give him right now fentanyl, or I need to think it's just because it's disease. I have to treat in hemodynamic way and I have to check preload, afterload, and everything. But it's really different way of patient of a reaction too. Of course, my elder patient that I need to reduce all the dose and all the side effect. But also, if you have a different category of surgery, if you have a surgery without neuromuscular blockade, maybe it's good to appreciate the vagal tonus, because if my patient is suffering, he will move. Okay. Or second, if I have a laparoscopic trend lumbar surgery, so you do know that we will get hemodynamic changes, and we want to appreciate and treat if it's pain or if it's pain nociception or if it's because hemodynamic changes. So this is the first question. Second, why? Okay, thank you. But why I'm doing this? has two answers. First, pain. If I want to keep my homeostasis, my equilibrium, so if I'm giving more than necessary opioid, I will get hyperalgesia and chronic pain. So patient came for surgery because pain of organ function, and after the surgery, you will get neuropathic pain. It's not that clever. And if I'm giving less than necessary, I will get central sensitization and also chronic pain. Second answer, hemodynamic. I need the same equilibrium. If I'm giving much more than necessary, I will get hemodynamic instability, hypotension, and I will use vasopressor if needed. But if I'm giving less than necessary, my patient will move, I will get blood pressure fluctuation, and I will get an unhappy surgeon. So this is just 3 little studies to picture my point. On your left, you have anesthesiology that managed to do the surgery with under remifentanil TCI and according to the level of NOL. And we reduce 30% of the doses. But more than that, we reduce the use of vasopressor. So hemodynamically speaking, every kind of vasopressor, phenylephrine, ephedrine, and everything. On your right, you have 2015 cardiovascular journal. According to the level of remifentanil during the surgery, you will get more pain in the recovery room. You hear me? So I'm giving remifentanil and my patient is more painful. Okay, because the side effects of remifentanil. And we do know now that we need to reduce the doses of remifentanil at the necessary. So, of course, more morphine consumption, more chronic pain, and more hyperalgesia. And the third study from this year too, BGA, we can see now, it's a logical thing, we did know that, but this is evidence-based medicine. 40,000 patient retrospective study, and they just want to appreciate hypotension and cumulative dose of epinephrine lack independent factor of acute kidney injury. And every time that I'm hearing, but for who you want to use it, for me it's very simple. You can see here that because it's an independent factor, we can see here that all the patients as are free and through, maybe, not maybe, they need a NOL monitor, I think, in order to reduce the amount of hypertension and the use of vasopressor. So it's really, really important to me to think on the target organ and to adapt the monitor to this doubt. Is there a doubt? We can use the NOL monitor, we can treat the patient, but first to think, we can treat the person by not being iatrogenic, not to give more than necessary drug to the patient. So this is my third video. Maybe someone can help me. Georgios, help me. Hello.
Να παίξουμε λίγο το βίντεο.
Wait, just a second. Pause. As in this video, I just want to share with you the step-by-step approach, and we will have a little exercise of how NOL monitor is working. Very simple. So you can play the video. Thank you.
At the center today we have total thyroidectomy with a patient in overweight. As we can see, she does have a big goiter. This is the trachea in the middle, and on the sagittal way you can see all along the goiter, left and right. So what I want to show you today is that I have to do the procedure without neuromuscular blockade. That means that I have to do a sequential assessment, and first of all, I have to see if the 731, if I see in my monitor of this, if I'm in the good shape. Its mean frequency is 12, but I also use ketamine, so that I know it's a little low. Secondly, I have to see on my NOL monitor if my patient
Just want to remember you, more than 10, less than 25.
He's experiencing a nociception activation, and we are under remifentanil in order to remain my patient stable all along the surgery. So 1.8, and here I can see an elevation. If it's during more than half a minute, I have to increase my remifentanil. Okay, so I repeat. First of all, hypnosis according to the beast. Second, I have the monitor of NOL, and thanks to him, I can do my anesthesia before my patient is waking up, moving, because we are under surgery of the throat. So it's very insecure surgery if she is moving. Last thing I just want to tell you, how can I remain in hemodynamic stability all the surgery? I have to reduce all the secondary effect of my drugs, and thanks to that, I can prevent using vasopressor in order to not to deteriorate my kidney function. And so it's very important to me to appreciate my hemodynamic state, also on the baseline from the blood pressure, second on the wide of the pulse pressure, and third on the perf index that we have here, that can give me the answer, does my drugs impact, influence my systemic vascular resistance?
Okay, as a very quick exercise, just want to show you how it's work in practice, okay? So we get a number of NOL, and
you can see elevation. So before there is an elevation, I want to wait for, but we have to increase now the remifentanil. And 2, just a little is sufficient, is enough in order to reduce our vagal balance. And you can see here that there is already modification on my pulse pressure, but I'm before is tachycardia activation and my respiratory activation. So this monitor of NOL is giving me where the balance sympathetic or parasympathetic is before I have hemodynamic respiratory or movement modification. Thank you very much.
This is a screen after surgery. Blood pressure completely stable all over surgery. And this is the way you're using NOL monitoring on everyday practice. So in order to remain on the right level of our drugs. So let's continue.
Hello everyone.
Okay. So now, how much I need to be precise. It's according to, if I'm willing to appreciate every day, my neurologic, my nociception, my hemodynamic state. And I just want to finish with the last part of this presentation with the perspective of the patient. This is a really important study for me, very simple. They ask 20 health patients, to do a trial. So they put them on the MRI machine, and on the ankle they have a heat stimulator. They have been hurting them until pain of 7 on 10, and they ask them how do you feel on a pain scale, on the anxiety scale. So that means that we are hurting them and we are asking them, are you painful or not? And please notify which number. But we have 4 steps. First of all, it was the baseline, and we get 7 on 10 for the average pain. After that, we did the same thing. We gave them a remifentanil infusion, and we told them that it will help them. It's a good opioid. We take care of the pain. It will be great. With smile, and it's help. You can see I have a positive expectancy, and I reduce my pain and I reduce my anxiety. And after that, we have 2 remain two measures. First, neutral. I am giving remifentanil and I'm measuring the pain, and it's not changing anything. But more than that, I can tell my patient, we're stopping to give you something to help. Now you just have pain, but we continue to give remifentanil. So according to the way I'm talking to my patient, I have different consequences. And more than that, because we are under MRI, we can do a functional MRI and we can see that we have different area on the brain. And for positive expectation, of course, we have the singular anterior cortex, and we have all the things that we can see on today on the hypnosis and different virtual reality. But if we are on a negative expectation, we have the higher level of pain in every step of this process trial, but my patient is receiving remifentanil, but is not feeling this. It's really, really important to me because we have to be in a humility way. That means that now we have, since my take-home message, my free take-home message, we're becoming more expert. We have more information, but we have to show some humility because we have to connect with the patient. And the first thing to do is to smile to him. And personal anesthesia means personal patient, and really important to me because it's really changed the culture of doing my everyday practice. And also, my second point here, we are changing the way as we are doing a good job. What is for you a satisfaction scale for an anesthesiologist? And until now, I'm going to the recovery room and I'm asking for my patient, do you have pain? And he's telling me on the 0 to 10, 0, and I was satisfied. We were reaching for the holy 0. But 0 pain don't mean that my patient is comfortable at all. And now we are changing this view. We reach for the right measure. We reach for doing the right thing for the patient. And this is leading me to my final conclusion. We expected benefit of your drug. We are giving. We have the most iatrogenic profession on medicine, I think. But when we are giving our drugs, we are reaching for the benefit. But what we are giving in excess, it's become a poison for the patient. So we have to monitor what we are doing, and we have to target the right measure of what we are doing. So it's Latin, primum non nocere. But okay, first, do not harm. So to conclude, in the perspective of the patient, it was a difficulty that it's difficult to me to adapt me to what happened to me. But now it's become a life experience. We need to maintain the autonomy, and we can be the helping doctor and not the one that decides for everything. So thank you very much for your attention, and God bless you all. Thanks.